Slides. So in the next 15 minutes, I will be talking about immunotherapy for cholangiocarcinoma. These are my disclosures, and I will give you just a few data about preliminary results with immune checkpoint inhibitors, and the most part of my presentation will be dedicated to the phase 3 TOPAZ-1 trial that has changed the standard of care in first line for patients with biliary tract cancer. So just to remind you that cholangiocarcinoma or biliary tract cancer is a rare cancer, but the incidence is increasing, especially for intrahepatic cholangio, and especially in countries that were historically at low incidence, like Europe or North America. And intrahepatic cholangiocarcinoma is the second leading cause of primary liver cancer after hepatocellular carcinoma. The prognosis is still poor, with a 5-year overall survival of less than 20%. And this is due to a late diagnosis. In fact, 60 to 70% of the patients are diagnosed with advanced stage of disease. And also, this is related to the high relapse rate. In fact, even if patients who undergo surgery then have a relapse in 60 to 70% of cases. So we need a better therapeutic approach and a better diagnostic approach. It's important to remember that biliary tract cancer is not a single disease. We have intrahepatic, perihilar, and distal cholangiocarcinoma, but we have also gallbladder cancer and ampulla of Vater cancer. And the different primary tumor sites are associated to different molecular or genomic alterations that you can see on your right-hand side in the slide. The most frequently observed are IDH1 mutation and FGFR2 gene fusions, but also HER2 amplification. And there is a difference in frequency of this alteration in intrahepatic versus extrahepatic disease. But for most of the patients, we don't have a target with targeted agents available, and we are still using treatment that are administered to all the patients, chemotherapy first, and more recently, immunotherapy. This slide summarizes the data with immunotherapy single agent. The KEYNOTE-028 was the first trial that tested pembrolizumab, anti-PD-L1, in patients with advanced biliary tract cancer with PD-L1 positive tumors. And in a small group of patients, 24 patients, the response rate was 13%. That was something interesting for patients with heavily pretreated biliary tract cancer. Unfortunately, the following KEYNOTE-158 trial did not confirm these results in the overall population. But what it was clear that it was that only subgroup of patients, so patients with a MSI high tumor, as already demonstrated for other tumor types, were the patients who really benefit from immune checkpoint inhibitor single agent, with an overall response rate of 41% and a median overall survival of 24 months in heavily pretreated patients. But unfortunately, MSI high tumors are observed in less than 5% of the patients with biliary tract cancer. And the other biomarker that can drive immunotherapy single agent, so tumor mutational burden, is almost never observed in patients with cholangiocarcinoma. So we don't have a biomarker, at least for most of the patients with cholangiocarcinoma. So the strategy was to combine immunotherapy with other drugs to try to improve the efficacy and to broaden the patient population that might benefit from the treatment. And here you can see the a summary of the LIPA-005 trial. It was a phase 2 study of lenvatinib, already mentioned, a multikinase inhibitor, combined with a pembrolizumab in patients with a previously treated cholangiocarcinoma. And the disease control rate was quite good, 68%, even if the response rate was not so impressive, just 10%. But as you can see in the waterfall plot, there is a clear benefit from this combination, with a progression-free survival of 6 months and a median overall survival of 8.6 months in previously treated patients. And this compares well with the data that with the results that we can achieve with chemotherapy. The other combination is the combination of immunotherapy plus chemotherapy. And this is a summary of the phase 2 trial combining cisplatin gemcitabine, that was the standard of care in first line, plus durvalumab, anti-PD-L1, plus or minus tremelimumab, anti-CTLA-4. And as you can see, the results are completely changing. The response rate is over 70%. That is really never seen before in biliary tract cancer, with a disease control rate up to 100%, and a progression-free survival of approximately 1 year. And that is the overall survival with chemotherapy alone, and a median overall survival of 18 to 21 months. This is a phase 2 trial, but based on these results, a phase 3 trial was designed and conducted and read out last year in 2022. And this is the TOPAZ-1 phase 3 trial. This is a simple phase 3 trial design, durvalumab, that is the anti-PD-L1 plus GemCis versus placebo plus GemCis in almost 700 patients. And the chemotherapy was administered for 8 cycles, as in the previous ABC02 trial that demonstrated the efficacy of the combination of GemCis. And then in the durvalumab arm, patients continued the immunotherapy until disease progression. In the other arm, the placebo. The patients enrolled in the trial are classic patients with advanced biliary tract cancer, intrahepatic, extrahepatic, and gallbladder, previously untreated. And patients may have had surgery at the diagnosis, followed by adjuvant chemotherapy, but at least 6 months, they could have been enrolled at least 6 months after curative surgery or adjuvant therapy. So patients with early relapse after surgery were not included in the trial. And the primary endpoint of the trial was overall survival. And it's not important to go into the details of the baseline characteristics, because as I said, the patients included in the trial are patients that we are used to see in clinical practice. The trial is positive, presented at ASCO GI 2022, and then published in the New England Journal of Medicine Evidence last year. And as you can see on the left, the overall survival curves separate after the first 6 months, and then remain very well separated, with 24 months overall survival of 25% in patients receiving chemotherapy plus immunotherapy versus 10% of the patients who received chemotherapy alone. The difference also in median overall survival is statistically significant, 12.8 months versus 11.5 months, even if these data are really inferior compared to the phase 2 data with the same combination. But anyway, the hazard ratio is 0.8 and the p-value is statistically significant. What is really interesting is that the curves separate after 6 months. The hazard ratio improved after 6 months from 0.91 to 0.74. So there is a clear benefit, a long-term benefit, but at least so far, we cannot identify which are the patients who really benefit from this treatment. And the updated overall survival presented at ESMO in September 2022 confirmed the benefit and the long-term benefit with a combination of chemotherapy plus immunotherapy. And also, it was shown a correlation and association between objective response and overall survival. So patients with objective response do better than patients with a stable disease, and patients with stable disease do better than patients with progressive disease as best response. This seems quite easy to understand, but it was not demonstrated for biliary tract cancer. Also, in terms of progression-free survival, there is a benefit, a statistically significant benefit with chemotherapy plus durvalumab versus chemotherapy alone. And again, we can see that the progression-free survival detached after some months and then remain very well separated, with a long-term difference in progression-free survival in almost all subgroups of patients analyzed. And the same is for overall survival. We have a statistically significant difference, 27% versus 19%. And at 12 months, 26% of the patients receiving chemoimmunotherapy remain in response versus 15% of the patients receiving only chemo. So there is a statistically significant benefit in all the efficacy endpoints. And in terms of safety, the combination is very well tolerated. Here you can see a summary. It's not important to read and to go into the details, but there are no significant new safety signals, no relevant adverse events observed adding durvalumab to chemotherapy. And also in terms of immune-mediated adverse events, I'm sorry for the slide, but the poster was had a very bad resolution, but just 13% of the patients had immune-mediated adverse events, and most of them were easily treated with steroids. And what is also interesting is here, I don't know if you can see these curves, most of the immune-mediated adverse events were observed during the first months of treatment and then decreased over time. And the other important point is that patients with immune-mediated adverse events seem to benefit more from the addition of immunotherapy or durvalumab to chemotherapy. This has been once again demonstrated for other tumor types, and it seems also for patients with biliary tract cancer. But this was a post-hoc analysis, and the trial was not powered to demonstrate this, but just an observation. Importantly, also, the quality of life was not worsened by the addition of another drug to the combination of gemcitabine cisplatin. Actually, the time to deterioration was numerically longer for patients treated with the durvalumab versus placebo, but there is no difference. So the quality of life is similar in the two treatment arms, even if we added one more drug. And also, several exploratory analyses have been presented during 2022 at the different conferences, and the efficacy and safety of durvalumab plus cisgem was confirmed regardless of the hepatitis status, regardless of region, regardless primary tumor location, intrahepatic or extrahepatic or gallbladder cancer, regardless of disease status, patients with initially unresectable disease and patients with recurrent disease, and importantly, regardless of the mutation status. These are post-hoc analysis, and the trial was not powered to demonstrate anything, but as you can see here in the forest plot, most of patients, there is maybe a signal in a different direction for HER2 amplification, but it's just a small number of patients. We cannot say anything, at least so far, but it seems that regardless of mutation status, all patients may benefit from the addition of durvalumab to chemotherapy. And this is a summary of the exploratory analysis. As I mentioned, at least so far, all subgroups of patients analyzed benefited from the addition of the durvalumab to chemotherapy. And based on this data, this is the algorithm published in the new ESMO guidelines, very recently published at the end of 2022. And based on the TOPAZ-1 trial, the new first-line standard of care for locally advanced disease and for advanced or metastatic disease is a cisplatin gemcitabine plus durvalumab, plus or minus, because some patients may have contraindications to immunotherapy. And for patients who have MSI high tumors, pembrolizumab were approved, for instance, in the US, is an option in patients with a previously treated tumors. Now we have the problem that if patients receive cisplatin gemcitabine plus durvalumab in first line, I don't know, but I don't think that pembrolizumab is a good option in second line. This data for pembrolizumab in MSI high patients were in patients previously treated with the chemotherapy, but not with the chemoimmunotherapy. There are other ongoing trials testing different combination in first line, gemcitabine cisplatin plus or minus pembrolizumab, and gemcitabine cisplatin atezolizumab plus or minus bevacizumab. And we will see these results soon at an upcoming conference. This slide is just to show you where we are with cholangiocarcinoma. In 2010, we had only cisgem, and now we have several options, chemotherapy, targeted agents, and immunotherapy in combination or as a single agent for MSI high patients. So it's really important to have a multidisciplinary approach to refer patients to a referral center so they can be offered all the treatments that we now have, or they can be enrolled in clinical trials with new drugs or combinations. So to conclude, durvalumab plus gemcis is the new first-line standard of care. There are ongoing trials with other combinations in first line and in following lines. There is a modest but real activity of single-agent ICIs with immune checkpoint inhibitors with durable responses, but this is true, at least so far, only for patients with MSI high tumor. We need to identify other subgroups of patients and other biomarkers. There are several open issues, but the most important thing is that we need more targeted and personalized therapy approaches also for immunotherapy, not only for targeted agents. So we need to better understand clinical and molecular characteristics, and we definitely need to identify biomarkers that may help select the patients who are most likely to benefit from different therapies. And thank you so much for your kind attention. And I will be happy to take your question.
Thank you very much, Lorenza, for this great presentation, as usual. I think there is Giuliano.
I don't want to steal the time, if anybody else want to ask questions, I just, otherwise I can ask, a general question. I congratulate for the really excellent talk. I am a fan, an old fan of 5-FU. Which is a cheap, old, very effective drug. I missed him. There is no place anymore?
Actually, I focus on immunotherapy, but there is still room for 5-fluorouracil or for capecitabine. For instance, capecitabine is the standard of care in the adjuvant setting. So after surgery, almost all patients receive a capecitabine for 6 months. And fluorouracil is used in the second line in terms of chemotherapy in combination with FOLFOX or with irinotecan or Naliri. So definitely in the adjuvant setting and in the second line setting in advanced disease.
Thank you.
Oh, you're welcome.
Can I ask you, Lorenza, probably I missed the point. Is there any ongoing study in the adjuvant setting for immunotherapy? Adjuvant meaning after surgery?
Yeah, not yet. It is designed with the same combination, cisplatin gemcitabine plus durvalumab. But the point is that now the standard of care in the adjuvant setting, as I was saying, is a capecitabine. There is an ongoing trial comparing cisgem versus capecitabine. And there is already a Korean study with the same comparison that was negative. So I think, but I'm sure about that, that the trial with immunotherapy in the adjuvant setting is put on hold, has been put on hold, waiting for the results of the trial comparing cisgem versus capecitabine in worldwide population, not only Asian. If the trial will be positive, I think the trial with the cisgem durvalumab will start in the adjuvant setting. If not, I think it's difficult. We have to rethink of the adjuvant, about the adjuvant treatment and which combination to improve the results compared to capecitabine alone.
Okay, thank you. Mr. Mohammed Hassam.
Hi, thank you very much, Lorenza, for a nice lecture. Did you add to study the microbiome signature in the biopsy when you are, of course, I am gastroenterologist and a clinical microbiologist. You know, when we discover by ERCP there is cholangiocarcinoma, we should detect it as early as possible. As you mentioned, biomarker, we should work on biomarker. Did you start to work on microbiome marker?
There are several studies looking at microbiome in patients with biliary tract cancer treated with immunotherapy, but to my knowledge, we don't have any data so far. But it's an important point because, as I said, we need to find biomarkers. We need to identify why the curves separate after 6 months and why at 2 years there is such a difference in survival. And we need to identify which patients really benefit from immunotherapy, and the microbiome is really important for immunotherapy. So
thank you very much. Well done.
It's a very important question, but I don't have the answer.
I see a question from the audience, from the chat. Dr. Marcello Di Martino has a question. Professor Rimassa, thank you for your excellent presentation. Do you think there is any room for neoadjuvant systemic therapy in biliary tract cancer? Could you comment on that, please?
Yeah, Definitely yes, because as I said, 60 to 70% of the patients who undergo surgery relapse. So we need to improve that, not only in the adjuvant setting, but also neoadjuvant. At the moment, we treat with a neoadjuvant, with preoperative chemotherapy, only patients who are not suitable for surgery. But there are ongoing trials in the neoadjuvant setting, and there are other trials that are planned and waiting for some other results to start. And I think, as in pancreatic cancer, the future will be to treat patients before surgery, also to see if the disease will remain limited to the liver or to the primary tumor site, or it will be early metastatic diffusion. So we will see in the near future.